Hello, good morning to everyone. This is Dr. Nisha Kaul, Professor and HOD Anatomy, Santosh Medical College, Ghaziabad. Today, I'm going to speak something about the surgical anatomy of thyroid gland. With respect to the essential facts about the anatomy of thyroid gland and anatomical basis regarding signs and symptoms of thyroid pathologies and precautionary measures to be taken and complications anticipated during surgical procedures involving thyroid gland. Now, this is a picture of normal anatomy of thyroid gland showing the blood vessels, the uh, structures related, and these are the pictures showing the pathology of thyroid gland, and this is a picture showing surgery being done on the thyroid gland. Now let's take up the normal anatomy of thyroid gland. It's a shield-like endocrine structure, as you can see here, and is situated in the lower part of front of the as well as on the side of the neck. You can see here. Its extension is from fifth cervical vertebra to the first thoracic vertebra and in relation with the fifth and sixth tracheal ring. You can see thyroid gland in relation to the thyroid cartilage and on the tracheal ring. Some special features. It's a unique endocrine gland in the respect that it synthesizes, stores, and then releases its excretion for the use only when it is required. It's a richest endocrine gland which has the richest blood supply, and it depends upon the external environment for its raw material, that is the iodine, to prepare the hormone. It's the largest endocrine gland and the only endocrine gland which can be palpated from outside. If we take up the dimensions, it is, of course, the shape is shield or butterfly-like. It consists of the two lobes and is connected in between by the isthmus. Each lobe is 5 into 2.5 into 2.5 centimeters. And this isthmus is 1.2 into 1.2 centimeters in dimension. And it's approximately 25 grams. On the posterior border, you can see the parathyroids. These are the two superior parathyroids and these are the two inferior parathyroids, which are shown as yellow colored pea-like structures. Now this is a picture showing thyroid gland. We are looking at it from the lateral side. This picture is showing thyroid gland related to thyroid cartilage to the trachea. Then it's related to the vertebrae C5 to T1, and it's also related to the strap muscles, that is the muscles which are very superficial on the anterior aspect of the neck. This picture again shows thyroid gland extending up to the thyroid cartilage and lying on the trachea with the isthmus covering the second, third, and fourth thyroid cartilage. Now, from the lateral lobe, from the left lobe of the thyroid gland, a pyramidal lake-like structure projects upwards, and this is called as the pyramidal lobe. This usually, by and large, it projects from the left lobe and it extends upwards. Now, conventionally, they say that it goes up to the hyoid cartilage, but sometimes it may not reach up to the hyoid cartilage and may stop and may remain non-attached. If it goes up to the hyoid cartilage, it is attached to the hyoid cartilage by a fibrous band, fibromuscular band, that's called as levator glanduli thyroidi. Usually people think that levator glanduli thyroidi is a remnant of thyroglossal duct, but that's not the fact. Levator glanduli thyroidi is not a remnant of the thyroglossal duct. Thyroid gland is surrounded from outside by coverings. They are called as the capsules. There are two capsules, a true capsule and a false capsule. The true capsule is condensation of the fibrous stroma. The false capsule is the derivation from the splitting of pretracheal fascia. One of the parts of the false capsule, which is on the posterior part over the middle of the thyroid lobe, it is thickened and is connected to the lateral end of arch of cricoid cartilage on either side of the midline. This is called as the ligament of Berry. This ligament of Berry is a very important ligament, a structure, because it's very closely related to the recurrent laryngeal nerve. Between the two capsules lie parathyroid glands along the posterior border, as has been shown in previous picture, and thyroid venous plexus lies deep to the true capsule. Now this is a picture showing the ligament of Berry, which I said is a thickened band of false capsule on the posterior aspect connecting the lobe to the cricoid cartilage. Since ligament of Berry is connecting thyroid gland to the cricoid cartilage. Now cricoid cartilage is connected to the thyroid cartilage. Both cricoid and thyroid cartilage, they are a part of the larynx. And we also know that during the process of deglutition, the larynx moves up. Hence, the thyroid gland also moves up during the process of deglutition. I again say, since thyroid gland is attached by the ligament of Berry to the cricoid in turn connected to the thyroid cartilage, both the two forming the larynx. And since larynx moves up during deglutition, therefore thyroid also moves up during deglutition. Now this anatomical fact should be used for the diagnosis of any midline swelling in the neck. If this midline swelling moves up and down during deglutition, this means it is derived from thyroid gland. Definitely it is derived from thyroid gland. Any swelling which doesn't move, midline swelling doesn't move up and down with the deglutition, most probably it doesn't come from the thyroid gland. Now this is a pictorial diagram showing the venous plexus of thyroid deep, and this is pretracheal fascia splitting, and this is the ligament of Berry. Now this is a diagram showing ligament of Berry and its relation with the recurrent laryngeal nerve. The same here, ligament of Berry and the recurrent laryngeal nerve. This is the venous plexus which surrounds the thyroid gland, and the venous plexus is drained by superior thyroid vein, middle thyroid vein, and the inferior thyroid veins. And this lies deep to the true capsule. This is again a pictorial representation of the venous plexus and a comparison of the venous plexus of thyroid with prostate. In case of thyroid, there are two capsules, the outer capsule, that's false capsule, and the true capsule, and the venous plexus lies deep to the true capsule. In comparison to that, in the prostate, there is an outer false capsule and the true capsule, and venous plexus lies between true and false capsule. Therefore, when you do surgery on the thyroid gland, we remove it along with the capsules, whereas in the surgery of prostate, we leave the capsules so that the veins, we only remove the part of the gland, we leave the capsules intact so that the veins are not injured and we want to avoid bleeding. Again, this is a pictorial representation of the capsules and the venous plexus lying in relation to the lying deep to the true capsule. So parts of the thyroid, there are two lobes and connected by the isthmus, and each lobe has an apex and a base. Each lobe, besides having apex and base, has got three surfaces: anterolateral, medial, and posterolateral. And there are two borders, anterior border and the posterior border. Now this is a lateral view of the thyroid gland showing covered by the capsule and showing the parathyroid deep to the deep capsule. If you take up the apex of thyroid gland reaches up to the inferior constrictor, up to the middle of the oblique line of thyroid cartilage, and is sandwiched between the inferior constrictor and superior sternothyroid muscle. And you can see it is related to the superior thyroid artery, and it's also related to the external laryngeal vein. Whereas the base of thyroid lobe is related to the fifth and sixth tracheal ring. It's related to the inferior thyroid artery, and it's related to the recurrent laryngeal vein. Now this is a posterior view of the pharynx showing thyroid gland and the vessels. Because in this diagram, we are not able to see the isthmus. Isthmus is not present posteriorly, isthmus is only present anteriorly. Hence, this is a posterior view of the pharynx and esophagus, and we are showing the two lobes of the thyroid gland with superior thyroid artery and inferior thyroid artery. And we are also showing the parathyroid glands related to the posterior border. This is the posterior border of the thyroid gland. Anterolaterally, it is related to the strap muscle, that is sternothyroid, superior belly of the omohyoid, sternohyoid, and anterior border of the sternocleidomastoid. Posterolaterally, it is related to the carotid sheath, which contains common carotid artery, internal jugular vein, and the vagus. Now, you can see in this diagram, the thyroid gland is covered by these strap muscles, which I have enumerated just now. And this is anterolateral surface. This is the posterolateral surface related to the carotid sheath and the contents, that is the carotid artery, internal jugular vein, and in between you can see a small part of the lower part of the vagus running downwards. Now, medially, thyroid gland is related to the two tubes, that is trachea, pharynx, esophagus. It's also related to the two nerves, external laryngeal nerve, recurrent laryngeal nerve, and it's also related to the cricothyroid muscle and to the inferior constrictor muscle. So this is the medial surface of thyroid. Here, thyroid gland is superimposed on it. So you can see thyroid gland is related to the two tubes, trachea and esophagus behind, then pharynx and larynx, again continuation of the trachea and esophagus, then two muscles, inferior constrictor cricothyroid, external laryngeal nerve, and the recurrent laryngeal nerve. These are the important relations of the medial surface of thyroid gland. The isthmus is covered by the strap muscles, and posteriorly it is related to second, third, and fourth tracheal ring. The terminal branches of the superior thyroid artery you can see anastomosing along its superior border, whereas inferior thyroid veins emerge at its inferior border. The anterior border is sharp and it's related to the anterior branch of the superior thyroid artery, whereas the posterior border is rounded. You can see this is the anterior border, and the anterior border is related to the anterior branch of superior thyroid artery. Now this is the posterior border, and the posterior border is related to the superior and inferior parathyroid glands and the anastomosis between the branches of superior thyroid artery and the inferior thyroid artery. This is a diagram showing the blood supply from superior thyroid artery and the inferior thyroid artery supplying the thyroid gland. This is superior thyroid, this is inferior thyroid, and this is a branch called as thyroideema. So if you take separately the blood supply, superior thyroid artery, inferior thyroid artery, thyroideema. Superior thyroid is a branch of external carotid artery, and you can see that it's accompanied by external laryngeal nerve. Inferior thyroid artery, a branch of thyrocervical trunk, and is accompanied by the recurrent laryngeal nerve. The recurrent laryngeal nerve crosses either in front or behind the artery, or it may pass in between its branches. You can see in this diagram, the recurrent laryngeal nerve is either passing behind, or it's passing in front of inferior thyroid artery, or it's passing in between the branches of inferior thyroid artery. Sometimes the recurrent laryngeal nerve may be a non-recurrent laryngeal nerve. It may not be a true recurrent laryngeal nerve. Now, in that case, the non-recurrent laryngeal nerve, which may run either above, you can see, or it may run very close to the inferior thyroid artery. So this fact has also to be kept in mind while doing surgery on the thyroid gland, that instead of recurrent laryngeal nerve, there can be a non-recurrent laryngeal nerve, and the relation is either running parallel above or lying very close to it. Now, thyroideema is a small branch which may either arise from the arch of aorta or brachiocephalic trunk, and it usually supplies the isthmus. The veins are usually three: superior thyroid vein, which goes into the internal jugular vein, middle thyroid vein, which goes into the internal jugular vein, and inferior thyroid vein, which are 3 to 4 in number. They anastomose and ultimately they drain into the left brachiocephalic vein. Sometimes there is a fourth vein called as Cocker's vein, which arises between middle thyroid vein and the inferior thyroid vein, and it also drains into the internal jugular vein. Now this diagram shows superior thyroid vein, middle thyroid vein. This is inferior thyroid veins, 3 to 4, which form a common inferior thyroid vein going into the left brachiocephalic vein. Now this is the Cocker's vein. Now of all these veins, the middle thyroid vein is a very short stump. It is a very short, has a very short stump. So while we are doing thyroidectomy and ligating these veins, We must not cut the vein. We must ligate the two ends of the vein by double knots and then cut. Otherwise, the vein is so small that the trunk of the vein, the stump of the vein may slip and it may lead to severe bleeding. Lymphatic drainage, upper group and lower group. Into the prelaryngeal and jugulodigrestic group of lymph nodes, the lower lip goes into the pretracheal and recurrent laryngeal nerve group of the lymph nodes. That is the lymph nodes which lie along the recurrent laryngeal nerve. As far as nerve supply is concerned, nothing important is related to thyroid because it's an endocrine gland. But yes, it has a sympathetic supply from postganglionic, from superior, middle and inferior cervical sympathetic ganglion, but they are all vasomotor in function. Parasympathetic is by vagus and recurrent laryngeal nerve, but the function is not known. Development of thyroid. Thyroid develops from the floor of the tongue as a diverticulum called as thyroglossal duct, which descends downwards, and ultimately by 7th week it reaches its exact site and it divides into two lobes. These two lobes, they form the two actual lobes of the thyroid gland, and rest of the thyroglossal duct disappears after 7th week. If this thyroglossal duct persists, it will lead to the thyroglossal cyst, which will be a midline swelling in the functions. It produces T4, T3, which will regulate the metabolic activity of most cells of the body, and it also stimulates the somatic and psychic growth of the body. Besides, thyroid gland also contains some cells, they are called as parafollicular cells. These parafollicular cells, they produce a hormone called as thyrocalcitonin, which lowers the level of the blood calcium. Now, a little bit about the parathyroid gland. As I said that these are two small endocrine glands about the size of the pea. There are two on either sides, but sometimes the number can vary up to 6. But in 80% of the cases, they are 4 in number. There are two superior and two inferior parathyroids. The superior parathyroids are constant in position and are situated at the middle of the posterior border of thyroid gland, lying between the true and false capsule. As far as inferior parathyroid is concerned, there is a variability in position. They may lie in the lower pole below the loop of the inferior thyroid artery within the false capsule, or in the lower lobe above the loop of thyroid artery outside the false capsule, or between the true capsule, beneath the true capsule, within the substance of the thyroid gland. Now, this anatomy also has variations of the anatomy also has to be kept in mind while doing thyroidectomy, because if you do a total thyroidectomy, that means you are also removing the parathyroid. Now, parathyroid glands are very, very important for regulating the blood level. Having said about the normal anatomy, that is shape, size, its in important relations, the blood supply, etc. Now let's come to the anatomical basis of thyroid pathologies. What are various anatomical bases of thyroid pathologies? The signs and symptoms. Then precautionary measures to be taken and complications anticipated related to the surgical procedures involving thyroid gland. Number 1 is enlargement of thyroid gland. Any enlargement of thyroid gland is called as goiter. This can be because of hyperfunction or because of hypofunction. Second is, what is the relation between the swelling of thyroid gland and the movement on the swelling? As I said earlier, thyroid gland is attached to the larynx, to the cricoid cartilage of the larynx by ligament of Berry. Now, when larynx moves up during the deglutition, obviously the thyroid gland or any swelling related to the thyroid gland will also move up during deglutition. So this is a small slide why thyroid moves with the deglutition. During first stage of deglutition, thyroid moves up, it pulls the pretracheal fascia up, which will pull the ligament of the Berry up, and this will pull the thyroid up. Now please see, this is the enlargement of the thyroid gland, and this is called as the thyroid, this is called as goiter. As I said, it can be because of hypofunction or hyperfunction. Now, this enlarged swellings of the thyroid gland, what can they do? The close relationship between the trachea and the lobes of thyroid gland commonly result in pressure on the trachea, resulting in patients with the pathological enlargement of thyroid. So if these huge swellings are there, they can compress upon the trachea and can result in the problem of in breathing. Massive thyroid goiters can compress, therefore. You can see these massive thyroid goiters compressing. They can compress the airways, esophagus, and recurrent laryngeal nerve. So massive thyroid goiters can compress trachea, can compress esophagus, and can compress recurrent laryngeal nerve. So this will result in dyspnea, dysphagia. Dyspnea means difficulty in breathing, difficulty in swallowing like dysphagia, and dysphonia. Dysphonia means problem in speaking, because dyspnea is because of compression of airway, dysphagia is because of compression of esophagus, and dysphonia is because of the compression of the recurrent laryngeal nerve. There can be retrosternal goiters also. The goiter's false capsule is thin along the posterior border of the lobe. So thyroid tumors tend to extend backwards and downwards. The false capsule is thick anteriorly, but it is thin along the posterior border. Therefore, if there is any thyroid enlargement, it doesn't move anteriorly. It tends to extend backwards and downwards, compressing the adjacent structures. The attachment of sternothyroid muscle to the thyroid cartilage effectively binds the thyroid gland to the larynx and limits the upward expansion. In the beginning, I said that the apex is related to the sternothyroid. It is sandwiched between sternothyroid and inferior constrictor. So beyond that attachment, the apex or its swelling cannot go. Hence, these are some of the factors which enable the thyroid swelling to go downwards. There being no limitation to the downward expansion, there is some limitation to the upward expansion, but no limitation to the downward expansion. So it's not uncommon for the pathologically enlarged thyroid gland to extend downwards behind the sternum. So all these features are explained only if you know the anatomy of thyroid gland or any variations in the anatomy of thyroid gland. A retrosternal goiter can compress the trachea and cause dangerous dyspnea or breathlessness. And not only that, it can also compress the veins in the thoracic cavity and will cause venous congestion. This is a diagram showing a retrosternal goiter going down into the thoracic cavity. Now, some important relations of nerves and arteries. As I said earlier, the superior thyroid artery is accompanied by external laryngeal nerve. Now, this artery is accompanied by the nerve, and the nerve goes down very close to the superior thyroid artery till it reaches the apex. Hence, when we do thyroidectomy, we must ligate the superior thyroid artery as close as possible to the apex so that we do not injure the external laryngeal nerve. Because the nerve runs very close to superior thyroid artery right up to the apex and then deviates from it. Therefore, for ligating superior thyroid artery, you must take a small part of the apex. On the contrary, inferior thyroid artery is related to the recurrent laryngeal nerve close to the thyroid gland. Below that, it is away. You can see the difference. Hence, for ligating inferior thyroid artery, it should be as far away as possible from the lower part of the thyroid gland. You should never ligate inferior thyroid artery close to the base. You should ligate it away, because when you take it, you look at the lower part, the recurrent laryngeal nerve is quite away from the inferior thyroid artery. A damage to external laryngeal nerve may result in the inability to tense the vocal folds, and it may result in the hoarseness of the voice. Now, this is a diagram. Here, two colored crosses are made. Red is do not ligate and green is do ligate. See, you should not, this is external laryngeal nerve and superior thyroid vessels. Don't ligate over here. Just ligate here, because at this level our external laryngeal nerve is quite away. This red is our superior thyroid artery, this is vein, and this yellow is your external laryngeal nerve. So we must not ligate it at a higher level, just ligate it very close to the base of the, very close to the apex of the thyroid gland. So precautions is that for superior thyroid artery close to the apex, and for inferior thyroid artery away from the base. Now some clinical anatomy related to the veins of thyroid. One is that unlike prostate, venous plexus of thyroid gland lies deep to the true capsule. Therefore, in surgical resection of the gland, the thyroid gland is removed along with the true capsule in order to avoid heavy bleeding as a result of injury to the venous plexus. And second thing is that middle thyroid vein is a short vessel of much importance in thyroid surgery. It bleeds profusely if torn because it is a very small stump. Hence, it must be doubly ligated and then cut before passing finger between the capsule of the glands in the process of delivering, especially intrathoracic extension of the goiter. This ligation of the middle thyroid vein should be very meticulously done. Doubly ligate it, then cut it before you start separating the thyroid gland because it has a very small stump and it can slip at once and can cause profuse bleeding. What is the relationship of recurrent laryngeal nerve? The relationship of recurrent laryngeal nerve to the inferior thyroid artery and to the ligament of Very does not follow a constant anatomical relation. Normally, we said that recurrent laryngeal nerve lies close to the terminal part of inferior thyroid artery, and below that it is away. But this pattern is not always constant. There may be variations, and what are the common variations? Number one is a variable relation with branches of the inferior thyroid artery, which I said that the recurrent laryngeal nerve may pass either in front, or it may pass behind the inferior thyroid artery, or it may pass between the branches of the inferior thyroid artery. Second is the relationship of recurrent laryngeal nerve with the ligament of Very, with the inferior horn of thyroid cartilage and a small projection from the lateral part of the lobe of thyroid gland that's called as Zuckerkandl's tubercle. Now, these are the relations of the recurrent laryngeal nerve with respect to the inferior thyroid artery, behind, in front, and between the branches. Then, with the ligament of Very. Although the nerve is generally located posterior and lateral to the ligament of Very, it can have a medial course with respect to the ligament of Very, and in some cases, an anterior branch can penetrate the ligament of Very. The later situation is considered as associated with the highest surgical morbidity, since the terminal branches might be completely hidden inside the ligament, and therefore sectioning during the final part of the thyroidectomy may lead to any problem. So this is the normal recurrent laryngeal nerve lying posterior to the and lateral to the ligament Very, but sometimes it may be medial to it. Here it is showing one relation, but it may be medial to it, or it may pass between the ligament of Very. Therefore, this anatomy has also to be, and sometimes even the recurrent laryngeal nerve is embedded within thyroid gland. So that thing should also be kept in mind while we are doing thyroid surgery, and this variability should be kept in mind by the surgeon. Now please see, this is the recurrent laryngeal nerve. You can see it's passing deep to the ligament of Very here also, but sometimes it can be medial to the ligament of Very and even embedded within the thyroid gland. This is the diagram you can see. This is recurrent laryngeal nerve passing superficial to the ligament of Very. This is piercing the ligament of Very, and it's passing deep. These three relations are to be kept in mind. Otherwise, there will be injury to the recurrent laryngeal nerve and hoarseness of voice. Now, this is Zuckerkandl's tubercle. It's a lateral projection from the lateral thyroid lobe. This is Zuckerkandl's tubercle. Now, recurrent laryngeal nerve passes just behind the Zuckerkandl's tubercle. Therefore, this Zuckerkandl's tubercle is a landmark for finding the recurrent laryngeal nerve during thyroid surgery. If you are not able to find the recurrent laryngeal nerve, this lateral projection, here it is a very small and a well-formed Zuckerkandl's tubercle. Now, this Zuckerkandl's tubercle is a very important landmark which helps in finding the recurrent laryngeal nerve. And its relation with the inferior horn of thyroid gland, it's seen piercing the larynx 0.6 plus minus 0.1 millimeter below the inferior thyroid cartilage. Now, as far as Zucker-Kendall's tubercle is concerned, this landmark and their mentioned distances to the recurrent laryngeal nerve can be taken into consideration as important surgical guidelines. You can see now. This is the Zucker-Kendall's tubercle, and you can see the recurrent laryngeal nerve. Again, this is here the Zucker-Kendall's tubercle, and this black line is shown as the recurrent laryngeal nerve. So, injury to laryngeal nerve, external laryngeal nerve injury will cause weakness and husky voice. Patients with unilateral vocal fold paralysis will present with post-operative hoarseness and breathlessness, and the presentation is often subacute. At first, vocal folds usually remain in paramedian position, creating a fairly normal voice, paramedian position. Definite vocal changes may not manifest for days or weeks. The paralyzed vocal fold atrophies, causing the voice to worsen. That's why it is a subacute condition. Other potential sequelae of unilateral vocal fold paralysis are dyspnea and aspiration. Dyspnea means difficulty in breathing. Aspiration means you inhale some fluid or the food particles because the vocal folds are not approximating. If there is a bilateral vocal fold paralysis after total thyroidectomy, if the surgeon is not aware of the variations of the relation of recurrent laryngeal nerve, vocal fold injury occurs due to the injury to the recurrent laryngeal nerve. And if a surgeon is not aware of the normal anatomy, I repeat, and its variations with inferior thyroid artery, with Zucker-Kendall's tubercle, then with the ligament of Berry, then one is bound to injure bilateral recurrent laryngeal nerve. This will cause bilateral vocal fold paralysis. This causes both the vocal folds, they remain in paramedian position, causing partial airway obstruction. Now, these are the pictures showing position of the vocal fold in unilateral, in bilateral recurrent nerve paralysis, and what is the picture seen when you like to visualize through the laryngoscope. Now, sometimes there may be a remnant of the thyroglossal duct. This can present as thyroglossal cyst, this can present as thyroglossal fistula, and this can present as cancer of the thyroglossal duct. Sometimes there may be ectopic thyroid tissue. Thyroid gland may not be at its proper position, it may be at some other position. So, various ectopic positions where thyroid gland can be seen are, since it arises from the tongue, the thyroglossal duct may not develop and it may not descend at all. So, you can see thyroid on the surface of the tongue, within the tongue. It can see above, behind and below hyoid bone. It can be seen on the larynx. It can be seen on the trachea. It can be seen on the esophagus. And surprisingly, pons, a part of the brain, thyroid gland, a remnant of thyroid tissue may be seen. Very surprisingly on the pleura, that's the covering of the lung, even on the ovaries. And it can be seen in a subdiaphragmatic position, like it can be seen on the gallbladder and adrenal gland. This is something very surprising as to how come a structure which is arising from the tongue and is going up to the neck and gets restricted, how can it go up to the gallbladder, to the adrenal gland, to the pleura, ovary or pons? Something very surprising. In a very short manner, the exact mechanism responsible for its abnormal descent is not known, but it is said that an error in the transcription factor like PIF1, NKX2-1, FOXE1, PAX8, mRNA, etc. are the responsible. Please remember that all organs, the organogenesis is under the control of the genes. If there is any error in genes, there may be abnormal position of any of the glands. So, these are some of the transcription factors which are usually responsible for the proper formation and descent of the thyroid gland. If there is something wrong with these genes, the thyroid gland may take an abnormal position. So, the references are from these sources, and thank you very much.